Good evening. My name is Dr. Theresa Pak. I am a fellowship trained reconstructive shoulder surgeon, and I am super excited to be here. Initially, I knew that my mom was registered for the webinar, but I just heard that there's about 200 other folks that registered. So I'm so grateful to be spending the evening with you talking about understanding and managing rotator cuff tears. So let's get started. So what is the rotator cuff? Well, in order to answer that question, we have to do a little bit of anatomy lesson. The shoulder is made of three bones: the humerus, which is the arm bone on the outside, the clavicle, otherwise known as the collarbone, and the scapula, which is my favorite bone, which is very nerdy to say, but hear me out. Scapula is also known as your shoulder blade, and it has two projections, one in the front called the coracoid, and another in the outside called the acromion. And that comes into play a little bit later about why that's important with its relationship with the rotator cuff. Other things that make up the shoulder joint are ligaments, muscles, and tendons, which is kind of the reason why we're here talking about this, and also the bursa. Now, the bursa is a fluid-filled sac, and when it's behaving, it does a great job of keeping everything moving. But when it's angry or when there's bursitis, what it does is causes a lot of pain and discomfort. So what is the rotator cuff? Well, the rotator cuff is made of four muscles and tendons. Now, this is an important relationship to know that muscles turn into tendons to attach to bone. And when we talk about the rotator cuff, we usually talk about the tendons, but it's really important to know what the muscle that's attached to that tendon looks like, because that can really help give us some ideas of what to do with treatments. The cuff is used to stabilize the shoulder joint, keeps everything in place, and also helps lift the arm. Now, the photo shows the rotator cuff muscles. In the front, we have our subscapularis. That's the big, juicy tendon in the front. We also have another one on the top called the supraspinatus. And in the back, we have the infraspinatus and teres minor. And you do not have to remember these names. There will not be a pop quiz at the end. I need to know the names of the rotator cuff tendons, but you don't. We can get to the rest later. So we went over the what. Now we want to talk about who gets rotator cuff issues. Well, evidently over 17 million patients in the US per year do. And that number increases after the age of 50. So happy 50th birthday. Now we want to talk about, well, why? Why does this happen? Why do we have issues with our cuff? The rotator cuff can be damaged in a couple of different ways, acutely and chronically. And there's a very important distinction that we want to make between an acute and a chronic or a degenerative tear, because our treatment is going to be different about what we do and when we do it. So acute tears can happen after a fall, such as a fall off a ladder, hopefully not while having any power tools in our hands, any car accidents, or lifting. But if I were to try to do a single arm overhead dumbbell lift with a 265-pound weight, I'd probably tear something or two. And with acute tears, what you can have is abrupt weakness. Your shoulder was completely fine. You had a bigger event or bigger trauma, and then you all of a sudden have a much weaker shoulder. That would be an indication to me that there might be something more acute going on, and a good time to get that checked out. Now, degenerative tears are obviously going to be more common. So what are degenerative tears? Well, degenerative tears are a natural part of aging, just like graying and all the other wonderful things that come with aging. And if you can imagine that the rotator cuff is kind of like the ends of a rope. In the beginning, the ends are nice and taut and clean, but over time, they can get degenerative and frayed. There was a study that was done, and it looked at all folks across all age groups, and they found that 50% of people over the age of 80s were found to have tears, but not everybody had any problems or issues. So the question is does everybody need something done? And the answer is not everybody needs treatment. Well, what happens when you do need treatment or your rotator cuff does cause you problems? So I'd like to go over with you next what I like to do in my approach to working somebody up that comes to see me about their rotator cuff. The first thing I do is ask about symptoms such as pain. How much pain do you have? Where does it hurt? What makes it hurt even more? Stuff like, do you have weakness or weakness with overhead motion, issues with that? And the reason that a lot of folks will come to see me is trouble sleeping. We know that sleep is very important, and we're starting to recognize the importance of sleep and how disruption of sleep can really affect somebody's quality of life. Another thing I like to ask is about history and medical history, especially. What kind of medical problems do you have? Do you have diabetes? Do you have any issues with your heart, lungs, kidneys? I also like to know, what kind of activities do you like to do? Are you working? If you're retired, do you like to golf or do tennis or swim? What kind of demands do you have on the shoulder? What do you ask your shoulder to do? One of the age-old jokes is, patients ask a surgeon, hey doc, can I play golf after surgery? And the surgeon answers, well, it depends. Were you able to play before? And for me, the answer is no on both accounts. But it's also good to know if you've had any surgeries on your shoulder before. I'd like to know if somebody else has been in there before and what they did, and also medications. Next, we go on to our physical exam. And the purpose of the physical exam is not to cause you any undue pain, but I do need to get some more information. And sometimes that does cause some discomfort. Specifically, I like to see where you have tenderness in your shoulder. Where does it hurt? Also, I like to do a range of motion test where I compare the range of motion from side to side, and also strength testing and other special tests. And once we get the exam out of the way, we want to talk about imaging. And the question that I get a lot is, do I need an MRI? Well, does everybody need an MRI? And the answer for me is no. An MRI for me is used as a surgical planning tool. I don't like to order imaging that isn't really going to change what we do. But having said that, I do like x-rays. X-rays are wonderful for me. They're fast, readily available, inexpensive, and easy for me to interpret. And somebody with an x-ray like this, I don't think I'm going to sign up for a rotator cuff repair when we could talk about other options that would be more reliable for them. Now we want to talk about treatment. But before we talk about treatment, we have to understand that rotator cuff tears are a spectrum. Rotator cuff pathology is a spectrum. On one end, you have impingement or bursitis. And if you remember from our little anatomy lesson in the beginning, we have that acromion, and sometimes the acromion can rub up against the rotator cuff that runs underneath it. Not always, but sometimes that impingement could cause some tearing. And sometimes that tear can get really big, like a full thickness tear, as you see in the image on the third image there. This is an arthroscopic image where we take a camera and look inside the shoulder joint. And that big juicy tendon there should be covering that whole bone. And then on the other end of the spectrum, we have something called rotator cuff arthropathy. Now, if you remember, I talked about the function of the rotator cuff, and one of the functions was to stabilize the shoulder joints. Well, in folks that have a chronic tear and it hasn't been working for a while, sometimes what can happen is the ball can move up and make contact with the other bones that are in the shoulder joint. And we call that rotator cuff arthropathy. So who gets what? As I mentioned, a lot of folks have rotator cuff tears, but not everybody needs treatment. If you're one of those lucky few that happen to have a tear, but don't have any symptoms, completely asymptomatic, and if you stay asymptomatic, guess what? We don't have to do anything. But let's say you're one of those few that's had a tear and now your shoulder's bothering you, or if you know that you've had a tear and the pain's getting worse, well, now where do we go? Non-operative treatment is one of the mainstays for rotator cuff treatment and pathology. One of those things is NSAIDs, or anti-inflammatories, such as Aleve or ibuprofen, which are over the counter, or meloxicam, which is a prescription. And the benefit of having that is it's a once-a-day medication. And also physical therapy. Nowadays, there's a variety of different ways to get your therapy. You can go to a formal physical therapist where you go in and have a therapist work with you. Other ways are remote therapy, where you are doing something online like we're doing now, or a home exercise program. My mom's on the line, and I think she has a rotator cuff tear on her right side, and I prescribed her some home exercises, and she'll tell us if one, she's been diligent with them, and if two, if it's been helping her out. Another non-operative treatment that I like to use is corticosteroid injections. Now, I don't like to make a huge habit of giving steroid injections, but I do definitely think that there is a role for them. The benefit of a steroid injection is that it gives a lot of more localized anti-inflammatory effects. And for me, I like to use ultrasounds because it shows me exactly where I'm going. It also gives me a sneak peek at the shoulder without having to send you to an MRI machine. It gives me some rapid information. Now, this slide is not put here to bore you, but this is a study that I really like in which the authors followed 452 patients with tears. These were full thickness through and through tears that were degenerative. And they told everybody, hey, you have to start with physical therapy. And they gave the folks an option whether or not to pursue surgery. And 75% of them did not need to undergo surgery at 2 years. They did a follow-up study at about 5 years and showed about similar numbers. So that just goes to say that not everybody needs surgery, and a lot of it can be treated with physical therapy and other non-operative modalities. But let's say we are having a discussion about surgery. One of the surgeries is an arthroscopic surgery, or what we call a camera surgery. This is a same-day procedure done on an outpatient basis, but you are put to sleep, and this surgery is very elegant. A camera is introduced into the shoulder, as well as other instruments through very, very small incisions. And it's wonderful and crazy, all the amazing stuff that we can do with such small incisions and small tools. If you look at the photos on the bottom, those are called our arthroscopic stills, or our arthroscopic photos. This patient had a very, very large rotator cuff tear. The tendon was moved around and freed up, and suture anchors were placed inside the bone to tack that tendon down and tie it down. And this is a shameless plug for a paper that I was involved with, and a study I was involved with, in which we looked at folks that underwent an arthroscopic repair of massive, and yes, massive is the scientific official term for these very large rotator cuffs. And what we found was that even in these really large tears, a lot of folks were able to achieve good results with an arthroscopic surgery. Now, I love arthroscopic surgery, and my preference is always for a minimally invasive procedure when possible. Caveat to that is, however, I don't recommend, and I would not recommend an arthroscopic rotator cuff repair if I don't think that there's actually a reliable chance of healing, or if there's underlying arthritis that wouldn't be addressed with the arthroscopic repair anyways. And when we're talking about that, we're then talking about a shoulder replacement. Now, a shoulder replacement is an open procedure, and the surgery would be something called a reverse shoulder replacement. Now, with a reverse shoulder replacement, an incision is made along the front of the shoulder, and the shoulder is a ball and socket joints. The beauty of the reverse shoulder replacement is that the ball is put where the socket was supposed to be, and the socket is placed where the ball is supposed to be, and it's reversed. And the reverse shoulder replacement answered a question that we had for a problem that we had for a long time. What to do with folks with large rotator cuff tears in which a standard or conventional or an anatomic shoulder replacement wouldn't work. Well, when the reverse came out, you don't need a rotator cuff or a functioning rotator cuff for this replacement to provide pain relief. For my surgeries, I do like to plan with 3D CT planning software. What the benefit of having a plan beforehand is if I'm able to get all the legwork done and the planning done before surgery, when it comes to the day of surgery, it's just going in and executing that plan. Now, surgeries is not without its risks, including infection, which has been shown to affect healing when doing a rotator cuff repair. And so one of the things that I like folks to do is to apply a topical cream. This is called benzoyl peroxide. It's an acne treatment medication, but it's really good at targeting the bugs that like to live on the surface of the shoulder. The other thing I recommend is if you're a smoker to quit, and if you're not a smoker, not to start. Smoking has been shown to significantly increase the risk of infection not in just shoulder surgery, but just pretty much surgeries across the body. Other medical problems such as diabetes can increase your infection risk. And if you are a diabetic, I do like to ask if your sugars are controlled and if you know your A1C. Other medications can also increase your infection risk, and those are the rheumatologic medications or rare medications, but that's why I like to get a good history. And also injections. So those corticosteroid injections, I would like to wait 3 months before doing a replacement and at least 6 weeks before doing arthroscopic surgery. Other risks with surgery include bleeding. So it's a good idea to let me know if you're on blood thinners. And pain. Yes, the goal of surgery is to reduce pain, but surgery itself is painful. We do try to minimize the amount of pain that you have. And one of the things that we do is we have the anesthesia team talk to you and see if you are a candidate for a nerve block. I also prescribe a lot of different medications post-operatively to help with the pain. And rehab. Surgeries do come with a rehab, and that rehab does include the use of a sling. And one thing to take away from this slide is this is the happiest you'll see anybody in a sling. You know, surgery, I believe, is a joint effort. I will do my best to give you my best. In return, I do ask that you follow the recommendations, and sometimes that recommendation does include a sling. And it's great to stabilize all the hard work that we did. And surgery, as I said, does not come without its risks, but there are inherent risks for everything. Our job as surgeons is to provide you the information that you need to make an informed decision. Thank you.
Our first question is, are there any specific exercises or stretches I can do at home to improve my shoulder health?
Sure. You know, there's a series of exercises that I like to give out to folks. And if you've ever seen those TheraBands, there are a series that's really focused on the muscles that are surrounding the rotator cuff, some of them going to be internal, external rotation, as well as low rows. And that can really help take some pressure off the rotator cuff and strengthen the muscles around the shoulder.
Thank you. Our next question is, following surgery, are there any restrictions or precautions I should be aware of during the recovery process?
Sure, absolutely. So depending on the surgery, everybody's rehab will be a little bit different, but sling is going to be in place for 4 to 6 weeks. When you are in the sling, though, however, it is really important that your elbow, your wrist, and your fingers don't get stiff. So I do recommend that every day you do take your arm out of the sling and move those joints. After the 4 to 6 week mark, I do begin with some passive range of motion, and we work very closely with our physical therapy team from there on out to see how much to progress and when to start active range of motion.
Thank you. That progresses into my next question. After treatment, how frequently should I follow up with you to monitor my progress or address any concerns?
Perfect. I see everybody at 2 weeks, then at 6 weeks, then at 3 months, and then at 6 months. And from there, I also do like a 1 year, and sometimes we'll send that out to 2 years as well.
Thank you. This question says, if I have a painful rotator cuff and keep using it, will this cause further damage?
Doesn't cause further damage. However, there is a risk depending on your age and activity level. If you do have a full thickness tear, that tear can progress. But in terms of causing more damage, I wouldn't say that you're doing anything wrong, but it's probably a good idea depending on your age and activity level to get it checked out.
Thank you. At what point does a rotator cuff tear require surgery to fix it?
Again, you know, my thing is coming up with the right treatment for the right patient. And so one treatment might not be perfect for patient A, and it's not going to be the same for patient B. In terms of a rotator cuff tear, if it's repairable and the muscle quality is good and the tendons look like they're good for a repair, that's a good time to get it repaired. But a repair isn't going to be successful if you already have underlying arthritis, because the repair doesn't really address that.
Thank you. This person would like to know, is there a point where I am too old for a reverse shoulder surgery?
The answer is no. And a lot of times I say, folks, it's not about your chronologic age, it's about your physiologic age. I do remember doing a reverse on somebody in their 90s, but they were 90 by chronologic age. But if you looked at them, I was looking at a 70-year-old. So no, nobody, as long as you're healthy enough and you have enough help at home, and you do understand that there are risks with surgery and those risks do increase with age, then I'm happy to be there to guide you through it.
Thank you. And are there any new technologies for reverse shoulder surgeries?
So reverse shoulder, the amount of technology and the innovation that's been going on, even in the past 5 years, has skyrocketed. The 3D planning software has been huge for me and my practice. The ability to plan everything out and have a good idea before going in has been incredible. The way that we're putting them in and the implants themselves every year, go to conferences and learn about all the new ways that we're putting things in and all the new companies coming out with things is very exciting. And one of the reasons why I chose to go into shoulder surgery.
Thank you. And our last question, can you tell us more about PRP? What is it?
So PRP is where we take blood, your own blood, we spin it down in a centrifuge, and we take out the platelet-rich factors, and we inject it just as we would with a cortisone injection. Now, the recent literature shows that it's very promising. However, it hasn't been around as long as corticosteroid injections. So at this point, insurance doesn't cover it, but I do offer PRP injections for the right patients, but just knowing that at this time, insurance has yet to approve it.
All right. Thank you so much for your time today. That is all the questions we have. We do ask you to stick around. We do have a survey at the end that we will try to launch, and we do appreciate everyone's thoughts.